Good evening, ma'am. My patient XYZ with age 8 years, sex by female, standard 3 class. Informant was a mother, which is reliable. Date of examination, date of admission was 3/2/2022, and date of examination was 5th February 2022.
Okay.
Admitted with chief complaint of difficulty in swallowing since 10 hours, difficulty in moving eyes since 10 hours, weakness of both upper limb and lower limb since 8 hours, and he also admitted weight loss since 6 months. History of present illness, patient was apparently all right till morning on the day of presentation. While having breakfast, she developed difficulty in swallowing water, which was sudden in onset, and she dropped the glass. It was associated with difficulty in moving eyes in both right and left direction, and developed slurring speech, but was able to understand the words told by her mother. Then she became semi-conscious and drowsy. Relatives gave her some water while coming to the hospital, after which she developed breathing difficulty and was oxygenated in the ambulance. She became unconscious 15 minutes before reaching hospital and remained in the same state for the last 2 days of hospital stay. These symptoms were not associated with any headache, vomiting, photophobia, no upward rolling of eyeball, frothing from mouth, tongue bite, spontaneous urination, no history of fall and head trauma, no history of lightheadedness, giddiness, tinnitus, no history of chest pain, palpitation, shortness of breath, no history of any evening rise of temperature, night sweats, no history of joint pain, rash. There is also no history of any back pain, neck pain, no history of any recent vaccination and dog bite. It was a similar kind of presentation. There's difficulty in moving eyes, slurring speech, in walking, difficulty in writing. 8 months back, for which she was repeatedly admitted, that is 3 times, and each time for 7 days. Admitted in the hospital and diagnosed with certain disease, for which she received 20 radiations, following which she completely recovered symptomatically and able to do her daily activities like reading, writing, and going to school. She has history of weight loss of around 10 kg in 6 months, as noted by her mother, in the form of loosening of clothes by 2 to 3 fingers. It was associated with a decrease in appetite. She used to take 2 chapatis in the night, which was reduced to 1 for the last 6 months. Previous to these episodes, patient had COVID-19 pneumonia and she required oxygen therapy during admission. Past history, no history of contact with tuberculosis, no history of any diabetes, hypertension, no history of any surgery in the past. Coming to personal history, the child studies in standard 3. Her performance in the school was quite good. No history of any difficulty in concentration, irritability. Having 2 brothers, all are doing normal. She has a mixed Indian diet, normal sleep, bowel activity, but she is having increased urination, that is around 4 liters for the last 1 day in the hospital stay. Not associated with any foul smell, blood and pus in the urine, and no frothing. Family history, no history of similar kind of illness, no history of consanguineous marriage among the parents.
Similar episodes.
No history.
You told us you had 2 similar previous episodes, no?
Ma'am, single similar episode in the past, 8 months back.
8 months back.
Yes, ma'am.
So shall we start discussing, ma'am? So we will start from 8 months back, I think, no? Would you like to describe that
yes,
attack which happened 8 months back? Okay, tell me. Okay. Tell me. Go ahead. Okay. I think you are going to describe that.
Ma'am, at that time, she was having difficulty in moving eyes, slurring speech, and imbalance in working, and difficulty in writing. And for which
this also happened over how many hours, onset to peak? This you told sudden, hyperacute, no?
Yes, ma'am.
So
these episodes were also, ma'am, developed suddenly, ma'am. For
suddenly,
which she was
3 times, yes. 3 episodes, huh?
Yes.
So in 8 months, she has 3 episodes.
No, ma'am, single episodes. But in that 1 month, she has been admitted 3 times. And for single day, she is relieved from all the symptoms and discharged from the hospital. But again, on the next day, she developed the same symptoms for which she was admitted again.
Okay. So we will, previous episode, it was not swallowing difficulty. It started with slurred speech. Huh?
Yes, yes.
So slurred speech,
Dif-
imbalance,
yes, ma'am.
and writing.
Writing, ma'am.
And similar kind of difficulty in moving eyes.
Moving eyes, yes, ma'am.
This also came within seconds, and onset to peak is how much time, ma'am?
Ma'am, all these symptoms developed.
Second episode looks like onset to peak is few seconds.
Yes, yes, ma'am.
This episode, previous episode, also few seconds only.
Yes, yes, ma'am.
Okay.
And it was maximum at the time of onset. These were not proved, sir.
Okay, so we'll start from what happened now. You told that this child had swallowing difficulty when she was taking liquids, no?
Yes,
so what happened when she was swallowing liquid?
Ma'am, according to her mother, when he was drinking water, suddenly she was not able to take water, and the glass dropped from her hand.
That's okay. That is due to hand weakness. Now we are discussing that swallowing complaint. You see, she had swallowing problem. No, that's what you told. Her illness started a sudden swallowing problem. So here we have to analyze, we have to localize slowly and then make a diagnosis. So sudden swallowing problem, or it was a hand weakness?
It was, ma'am, both were there, ma'am.
Difficulty in swallowing. That's what you have written. No?
Yes. Yes, ma'am. First symptoms was difficulty in swallowing.
Then that means it was not due to hand weakness. She might have dropped the glass, but swallowing difficulty means it is a different symptom. No. So what are situations you can get swallowing difficulty, and how you analyze that symptom is the first question you have to ask. So swallowing, as you know, has got so many. It can be due to neurological causes, in which there are several phases. It can be psychological causes, or it can be due to medical causes. No? You can have general medical situations, you can have psychological, neurological. So let us forget about general medical and psychological, because they do not come acutely like this. You got globus hystericus and things like that. Whereas medical causes will be pharyngitis, retropharyngeal abscess. No? Those things are painful swallowing defect with systemic features. So those things we will not discuss now. So it's an acute onset swallowing difficulty. So you have to describe the phases of swallowing. You have got a oral phase, you have got a pharyngeal phase, you have got an esophageal phase, and you have got a supranuclear control. Supranuclear control of swallowing consists of, one is supranuclear centers, one is the taste center in the insula. You have got the mouth area in the superolateral surface, no? And you have got the vomiting center in the chemoreceptor trigger zone. So supranuclear centers on the brainstem centers, which are concerned with sending out the food. Then the taste appreciation in the insular region, and the motor schema in the motor area and the supplementary motor area. And you have got an affective component which comes from the frontal lobe. So these are the supranuclear areas which are concerned with the swallowing. So we will see which caused the swallowing problem in this child, whether it is infranuclear, supranuclear, oral phase, pharyngeal phase, or esophageal phase. Oral phase swallowing, so that history you should elicit. When somebody is telling swallowing difficulty, don't jump to tell about the dropping of the glass. So was the child having oral phase? So oral phase of swallowing involves putting the food in the mouth. Then you will have to chew. And once you chew the food will be in the floor of the mouth as well as in the gingivolabial gutters. and whatever food is there in the gingivo-labial gutters, you push it to the floor of the mouth. And when it comes to the floor of the mouth, you put it on top of the tongue. From the top of the tongue, it is rolled back. So chewing involves which muscles? Muscles supplied by the fifth nerve, muscles of mastication. That is medial pterygoid, lateral pterygoid, temporalis, and masseter. So if that is weak, patient will say, when I put the food in my mouth, my jaw hangs. Acute severe myasthenia. Patients can come with acute severe myasthenia. So the patient will tell, when I am putting my food in my mouth, the jaw hangs. So I cannot approximate my lower jaw with the upper jaw. Or when I try to bite is so weak that the food doesn't get broken. Or you may have a stiff jaw, like conditions like tetanus and tetany, where again you are unable to close your mouth and chew, but your jaw is stiff and tight. So that is the chewing phase. So if that was not there, the muscles of mastication are normal. Then the food in the gingivo-labial gutters is pushed to the floor of the mouth by the buccinator. So buccinator is supplied by the facial nerve. So facial nerve weakness means buccinator will not be able to push it. So food will remain in the gingivo-labial gutter, and patient will have to push the food with the fingers into the floor of the mouth.
Okay.
And so generally they do that. And once they bring it to the floor of the mouth, the food should be contained inside the mouth. So if the orbicularis oris, which is supplied by the seventh nerve, is weak, food will leak through the sides of the mouth. So is the food remaining in the gingivo-labial pouch? Is the patient using the fingers to put it to the floor of the mouth? Or is the food leaking through the sides of the mouth? All this will tell us whether the seventh nerve is involved.
Yes.
The oral phase involves the fifth nerve, seventh nerve, and 12th nerve.
Yes.
Fifth nerve, I told what are the features you should ask, and seventh nerve is food remaining in the gutters and food leaking through the sides of the mouth.
Yes.
So that is seventh nerve. Then come if these two are all right, fifth and seventh is all right. Then the 12th nerve, the intrinsic muscles of the tongue will push the food from the top of the mouth to the pharynx. So the food remains in the mouth itself, and it might leak through the middle of the mouth. Facial weakness, it will leak through the sides. If it is a tongue weakness, it will drop through the center.
Yes, sir.
And patient will not be able to roll back the food. So if these things are there, any of these things are there, or more than one is there, you know it is the oral phase, which involves three nerves: fifth nerve, seventh nerve, and 12th nerve. If this is all right, then we'll go to the pharyngeal phase. Pharyngeal phase is mainly the 9th and the 10th nerve. What do? These nerves close the laryngopharynx when you are swallowing. So you've got a oropharynx and the laryngopharynx. The laryngopharynx should be closed when you are swallowing, so that the food does not go to the respiratory passages.
Yes, sir.
So if these muscles are weak, food will go to the respiratory passage. So patient might cough when he is swallowing, and if it is little severe, patient will have nasal regurgitation and nasal twang. So is the patient pharyngeal phase, patient will swallow and then he will have coughing, or the food will go through the nose and nasal regurgitation and have a nasal twang during speaking. That is the pharyngeal phase. In the pharyngeal phase, we say that you have got LMN, you have got UMN.
Yes, sir.
The non-neurological part I will tell last. Non-neurological conditions are there, like obstructive conditions, those things we will tell later. This is neurological cause. If you have got a difficulty in swallowing liquids, what is the difference between difficulty in swallowing liquids and solids? You said it was liquid for this patient.
Yes, ma'am.
Liquids need quick coordination. Liquids will be very slippery. So liquids need a quick coordination. Solids need a powerful coordination.
Yes, ma'am.
So neurological disorders, they neither have quick coordination nor have powerful coordination. Because of that, neurological cause, both liquids and solids will be difficult.
Okay.
Semi-solids will be easy. If it is upper motor neuron, liquids are more difficult than solids, because liquids need fine coordination of the movement because of the quickness in which the liquids slip. So early onset liquid difficulty, and over some hours or some days, the solids are also becoming difficult, then it will be upper motor neuron. If both are difficult, it is generally lower motor neuron, because neither powerful action is there nor quick action is there. So supposing you have got a mechanical obstruction in the upper esophagus, liquids will be easy. Solids will be difficult. You see, liquids will find themselves seeping through the narrow passage left in between the obstructive pathology. So it will leak, whereas solids need space. So when there is an obstructive tumors or something in the upper esophagus, then solids will be difficult, liquids will be easy. Neuromuscular conditions like achalasia cardia, liquids are difficult, solid are better, because solids will, there is no obstruction. In conditions like achalasia cardia, there is no obstruction. So solids will drag themselves by their weight. Liquids will have poor fine coordination. So obstructive pathology, liquids are easy. Conditions like achalasia cardia, solids are easy. Neurological conditions, both liquids and solids are difficult. Where in the pharyngeal phase, patient will cough, have nasal regurgitation, and have nasal twang. If it is upper motor neuron, liquids become difficult early. And if it is lower motor neuron, both becomes difficult early, because neither powerful action nor quick action is there. So these questions you will ask to know whether it is the pharyngeal phase swallowing. Third is the esophageal phase. Oral phase is all right. Pharyngeal phase is all right. But when the food goes into the esophagus, patient feels a stuck feeling, like polymyositis, scleroderma. You see? First the esophagus. This is the esophageal phase in a, or you have got tumors, esophageal tumors. Polymyositis, upper 1/3 of the esophagus contains skeletal muscle, so it will be affected. So then the food becomes chewed, pushed back, no coughing, no nasal regurgitation. When it goes to the esophagus, it becomes stuck there. So patient will say, I will have to pour water and push my food down. It becomes stuck. That is esophageal phase. So if you ask all these three questions, we will know whether it is an LMN swallowing problem, oral phase or pharyngeal phase or esophageal phase, or if the patient is continuously having liquid easy and solid difficult, and in the esophageal phase, it may be a mass lesion. If it is reverse, it may be achalasia cardia, or if it is a painful or odinophagia, inflammatory lesion. Odinophagia is inflammatory lesion, and psychogenic, patient will have periods of swallowing difficulty and periods of normality, which does not happen in organic conditions of either medical nature or neurological nature. So this much is lower motor neuron, oral phase, pharyngeal phase, esophageal phase. In upper motor neuron, patient will have coordination defect. So it is, liquids are more difficult than solids, and patients usually have pseudobulbar features like uncontrolled laughter, uncontrolled crying, and nasal tongue, of course. So upper motor neuron presents with liquids more than solids, and pseudobulbar features, other pseudobulbar features like uncontrolled laughing, crying, emotional lability, all those things are present. What is the role of the link to the insular region in the upper motor neuron? Supposing you are given something which you know is poison, so the insular region will tell this food is not okay for you. So it will come down, activate the vomiting center, so patient will vomit out. And supposing you are a vegetarian and you are told to eat non-vegetarian, your frontal limbic areas will come and tell, spit it off. No, that is the affective component. So for frontal lobe is affective component, Insular region is appreciation of taste as favorable, unfavorable, dangerous, and the motor area to prepare the motor schema, that is the mouth area. So that is a supranuclear control is from frontal for the affective component, insula for the taste, and the motor area for the motor schema.
Yes.
Commonly, we are thinking about the motor component. That is why I am telling pseudobulbar effect and liquid system call it. Whereas insular area is a natural thing which God has given us to protect ourselves against dangerous food eating, and limbic component by the set goals. You know that certain things are forbidden. Some of us are vegetarians. Some of us are selectively not using certain kinds of food materials. So that is the limbic component. Supposing you go to Kashi, you leave off one food. That is southern India. So you leave, you have left your food, and then your limbic system should don't eat it. You have left it off, no? So those kind of limbic components is from the frontal lobe. So if if you have elicited all these symptoms, I will know what was the swallowing difficulty. Was it in the oral phase? Was it in the pharyngeal phase, esophageal phase, or upper motor neuron, or a painful swallowing defect? But none of this information is available to us, so we do not know. So there was a swallowing defect. So when you see the next case, you will take all this history so that we will know, localize what is the cause for the swallowing. So something happened in the brainstem, either in the lower motor neuron or in the upper motor neuron, it could be, or acute severe muscle paralysis. It's acute severe muscle paralysis in a child. So one thing, brainstem, where all the cranial nerve nuclei are there, it could be one cause. Just to think of the swallowing, rest of the thing I'm not going into now. Next, can there be an acute severe element syndrome? Supposing you have got a Udigi-Dollar syndrome, like that people tell in Bangalore, some kind of a tick is there. So the tick, if it is biting somewhere, at one point a critical dose of neuroparalytic toxin gets injected into the patient, they severely develop ophthalmoplegia and they develop swallowing difficulty. They can also develop upper motor neuron syndrome. It comes very hyperacutely. So they can get hyperacutely tick bite. That is Udigi-Dollar syndrome, it is called, who live in the unprotected small houses where there is lot of access for the insects. Then you can have neuroparalytic envenomization by snake bite, or black widow spider bites. No?
Yes, ma'am.
These things can produce acute severe weakness. And next year's group of conditions where you can get this acute severe weakness is vascular conditions. If you have a brainstem arteriovenous malformation, we call it as Weiband-Mason syndrome. Very common. It is seen in children, not adults. Weiband-Mason syndrome, you have got brainstem AVM, which may be associated with AVMs in the retina. Or it may not be, may or may not be, but it is brainstem AVM. It is called Weiband-Mason syndrome. So these are arteriovenous malformation. In some situations, suddenly a steal happens. So it is like an acute posterior circulation stroke. So patient will develop all the brainstem features due to the steal effect. Children, because the child, I am not telling about a posterior circulation stroke, which we will think first in the adult. It is in fact a stroke which happens in child due to the steal effect of an arteriovenous malformation. Third group of conditions, because it is so acute, no?
Yes, ma'am.
Third group of conditions which can affect the brainstem is acute severe demyelination. So these are the possibilities. Is it a neuroparalytic syndrome? Is it an ischemic syndrome? Is it a demyelinating syndrome involving the brainstem? So these possibilities we will think after sorting out the cause for the acute severe swallowing defect. Second thing this child got was she dropped the object in the hand. That means she was holding it, so her power grip was weak. Precision grip is mixing food, holding the pen, writing everything. But she was holding a glass. It's a power grip. That means the flexors of the hand became weak.
Yes, ma'am.
So was it at the lower motor neuron level or the upper motor neuron level? We do not know because it was so sudden and severe. We know that the power grip became weak, long flexors became weak. What level? If you have additional features like the limb was stiff, all those our examination will show us. Now for dropping, we can only tell that the power grip became weak. Because in upper motor neuron, what goes first is the precision grip, and the limb will be stiff and there will be exaggerated reflexes. But in lower motor neuron, it can be depending on the nerve or the root. Any territory can go weak and it will be flaccid and reflexes will be depressed. In this case, now you have no time to time for the child to write or do anything, so that we do not know whether the precision grip was there or not. So we cannot comment anything. The upper limb became weak first. That is all. Next, you told the child's eye movements became frozen. So eye movements, it was symmetrical bilateral. It did not evolve from one eye to another. So one eye to another, if it has evolved, I could have still thought about all the element syndromes where there is a neuromuscular junction, acute severe myasthenias, or all these toxins, poisons, conditions which you discussed, we can consider. But you did not mention about the drooping. You said that the eye movements got frozen. Did the child have a drooping?
No.
No. So in that case, we have to put the gaze center. Eye movements were frozen, but there was no drooping. In that situation, it is less likely to be at the element level. It was probably at the brainstem level. The brainstem, you have got the gaze center, you have got the oculomotor nuclei and their supranuclear connection that is in the pons. So you have swallowing difficulty, that is, if you put in the brainstem, it is in the medulla. And then you are having eye movement abnormality without drooping of the eyelids. So eye movement abnormality with the drooping of the eyelid, with diplopia, with squint, with pupillary involvement. Like that only we analyze. But in this child, again, it happens so quickly. You do not know whether the child experienced any diplopia. What about the pupillary asymmetry, which that people would have noticed? Was there a squint? None of those information is possible because it evolved over seconds. So only point is, supposing you have got eye movement abnormality with double vision and squint, it points to a lower motor neuron. Presence of squint, presence of double vision, and you usually have ptosis if the third nerve is involved, or with or without ptosis. So presence of subacutely evolving eye movement abnormality with a squint and double vision points to a lower motor neuron. Upper motor neuron problems do not produce squint, they do not produce double vision, with only one exception, that is skew deviation. If there is a skew deviation, that is called vertical disconjugation of the eye due to supranuclear cause. Skew deviation is vertical disconjugation, not horizontal. So only one supranuclear cause will produce squint, that is skew deviation, which will be vertical disconjugation of the eye, and patient can have vertical diplopia, but it differs from the vertical diplopia of superior rectus or inferior rectus or superior oblique or inferior oblique. All these muscles can produce vertical diplopia in the element, but the skew deviation, vertical diplopia remains constant in all planes of action. Whereas in neuroparalytic vertical diplopia, the separation of images will be maximum when you move the eye in the plane of direction of the paralyzed muscle. There is an eye movement class which I have taken that you can go through. Now, supranuclear causes do not produce diplopia, do not produce squint, but the exception is skew deviation, where both happens. How are you going to differentiate? That's what I am trying to tell you. Squint will be vertical only, never horizontal. So skew deviation squint is always vertical and never horizontal. Second, the diplopia is also vertical, never horizontal. And this diplopia is unique in that, unlike the vertical diplopia due to neuromuscular paralysis, this vertical diplopia remains constant in all planes of eye movement. Supposing you are looking up, looking down, looking to the right and up, looking to the left and up, then the vertical separation remains constant in all planes. There is no plane of maximum separation. So supranuclear diplopia occurs only in one condition if you have MCQ. It is skew deviation, and the skew deviation is always vertical disconjugation, never horizontal, and the diplopia does not have a plane of maximum separation of the true image and the false image. The presence of horizontal diplopia, vertical diplopia, presence of skinned, and skinned with a plane of maximum separation is LM. So whereas eye movement abnormality without any ptosis, without any skin, without any diplopia, I would like to consider the gaze center getting involved, that is PPRF, parapondine reticular formation, which is located in the pons. So considering this history as correct, we are discussing. So I started with following. Let's imagine whether the lower cranial nerve got involved at some level, then it is medulla. Second, it is eye movement paralysis, so it is going to the pons. Third, she dropped her object from the hand. She dropped it due to weakness or incoordination, we don't know, because you said that during one episode she had unsteadiness. So if it was weakness, we will say that the upper limb area got involved in the corticospinal tract, which is traveling the brainstem. Or if it is incoordination and drop, it is brainstem connection to the cerebellum. It is connected to the cerebellum, then it becomes a brainstem cerebellar syndrome. For that, we need more information. Was she dropped it because she was shaking, or she dropped it because she was drowsy, or she dropped it because she was weak? All this we have to imagine only, nobody can tell. And when a disease evolves so quickly, I am sure that the relatives cannot also tell us. So if they tell that the child's hand shake this side, that side, and she dropped it, it becomes a brainstem cerebellar syndrome.
Yes,
she left the power and dropped it, it becomes a weakness involving the corticospinal tracts. Or if she became just drowsy and left it off, it is due to involvement of the brainstem reticular formation. Because a brainstem lesion, child becomes drowsy because consciousness has got two components. One is the depth, another is the content. The depth of consciousness is because the child became semi-conscious so quickly, even though we did not get detailed history regarding the phases of swallowing or the evolution of eye movement, the drowsiness indicates that if it is at the extracranial level, drowsiness will not happen. So drowsiness indicates we are probably right that everything is intraaxial. Depth of consciousness is located in the, I am only answering why, because 1 hour now. I want to tell maximum number of points. That's why I'm not asking you a question. You understand, ma'am?
Yes.
I am answering so that I give you the points, because once the teacher gives you, you keep it in your mind and fix it. That's all, no?
Yes,
More time gets lost, no?
No, yes, ma'am.
So consciousness has got two things. One is the depth, another is the content. Depth of consciousness is maintained by the ascending reticular activating system.
Yes,
it is in the brainstem. Whereas content of consciousness is in the hemispheres. If the content of consciousness is affected, person will be delirious, hallucinating, talking irrelevantly, becoming agitated, aggressive, may throw seizures. Whereas if the depth of consciousness, which is in the ascending reticular activating system in the brainstem, is affected, patient becomes drowsy. So in this patient, 1, swallowing difficulty, 2nd, eye movement problem, 3rd, drowsiness. So all this can be put in the brainstem, medulla, pons, and ARAS. Medulla to explain swallowing, pons to explain the eye movement, and ARAS to describe the semi-consciousness, the weakness. Was it extension of the pathology to cerebellum or due to corticospinal tract? We do not know. information is less. And relatives gave her some water while coming, after which she developed breathing difficulty.
Yes, ma'am.
That means what? So that is an important point. In fact, her swallowing part was in the pharyngeal phase. You see, we thought oral phase, so many features, pharyngeal phase, so many features, esophageal phase, so many features. So now that relatives have given you a very good history. When they gave her water, she developed breathing difficulty. That means the food, instead of going to the stomach, it went into the lungs.
Yes, ma'am.
That means clearly it is the pharyngeal phase swallowing difficulty. Because of that, it leaked into the lungs and resulted in breathing difficulty, and she had to be oxygenated. So we have got some more information, that is, for swallowing was in the pharyngeal phase, because the child developed breathing difficulty while swallowing. So this is an acute brainstem lesion involving the medulla, pons, and ARS. What is the next symptom? Next symptom. What is the next symptom? Became unconscious. So the depth became completely affected 15 minutes before reaching the hospital and remained in the same state for 2 days of hospital stay. So it's an acute severe brainstem syndrome. So now what are all the differential diagnosis? One is vascular assay. So acute severe brainstem syndrome. It's a brainstem syndrome. It is not an element syndrome. So one is vascular. So is the child having a Weber-Mason syndrome, brainstem AVM with steel? Very strong possibility. Second is the child having an acute severe demyelination. Third is the child having any bleeding disorder. So a brainstem hematoma. Supposing you have got a clotting factor defect, some bleeding disorder, or some platelet dysfunction due to whatever cause, then you can have acute severe syndromes, ischemia, hemorrhage, demyelination. These are the things which happen acutely. So it came acutely. So I will think 3 possibilities. Was it a vascular phenomena due to an AVM producing a steel, or it can still be a vertebrobasilar ischemia. Supposing you have got craniovertebral junction anomalies. Soft tissue anomalies are there, bony anomalies are there. Bony anomalies will present with short neck, limitation of neck movement, painful phenomena during neck movement may be there. But soft tissue anomaly like Arnold-Chiari malformation, they need not produce the short neck or the painful limitation. Instead, they can produce acute vertebrobasilar ischemia in a child. So is the child having an ischemia due to soft tissue malformation in the craniovertebral junction? Is the child having an arteriovenous malformation which is producing a steel? Or is the child having a bleed due to a bleeding disorder due to platelet dysfunction or clotting factor defect, or any cause which has produced an acute bleeding syndrome? Third, demyelinations can sometimes be hyperacute. Hyperacute demyelinations are there. So is it a brainstem demyelination? These are the 3 possibilities I will consider for this child at this point of time. There was no giddiness, so okay. So these are the location is medulla, pons, ARA, and it could be ischemia or hemorrhage or demyelination. Ischemia due to AVM, or due to soft tissue anomalies in the craniovertebral junction, or a bleed due to any bleeding cause, or it could be an acute demyelination. These are the possibilities we will consider at this point of time. Then you told previously the child had one more episode 8 months back.
Yes, ma'am.
That episode was associated with eye movement problem. So that could be gaze center, imbalance while walking. So that points to probably a lesion which is involving the brainstem and the cerebellum. Because you are telling gait imbalance. No? Was it a stiffness or a dragging or a ataxic gait? When you tell imbalance, I am thinking it is a ataxia. When the syndrome is predominantly brainstem and gait ataxia, it could be either a middle cerebellar peduncle or an inferior cerebellar peduncle. So middle cerebellar peduncle, because pons is connected to the cerebellum by the middle cerebellar peduncle, and it contains the corticospinal tract and corticopontocerebellar fibers. So you will get a spastic ataxia if it is a middle cerebellar peduncle. If it is inferior cerebellar peduncle, you will have no spasticity, but a reeling gait with vertigo and nystagmus. That is inferior cerebellar peduncle. So because you said imbalance, I am thinking it is a brainstem and cerebellar connection. Is it an MCP or an ICP? Depends on the accompaniment. If the accompaniment is spasticity, it is MCP. If the accompaniment is a reeling gait with vertigo and nystagmus, it is inferior cerebellar peduncle. Yes. So it's a brainstem cerebellar syndrome in the previous episode. And she improved completely from that, or she was left with residue?
Yes.
Was she having any residue from the previous episode?
No, ma'am. According to her mother, after that, but ma'am, in that 1 month, but in that 1 month, ma'am, she was repeated 3 times. After that, she completely became normal.
Normal. Yes. So now maximum localization from the history is medulla, pons, ARAS with its cerebellar connection. So it is a brainstem cerebellar syndrome involving the middle and the lower brainstem and its cerebellar connection. That's 1 point. Acute onset, brainstem cerebellar. 3, relapsing remitting. So these are the key features in this patient. And what is the peculiarity of the relapses and the remission? It is in the same site.
Yes, ma'am.
Site specific. So it's an acute syndrome. Always onset to peak is very short. It involves brainstem and cerebellum. It is relapsing and remitting, and it is in the same site. So if it is in the same site, among all the 3 DDs we have put as an infarct, AVM, or bleed, or demyelination,
yes, ma'am.
when it is relapsing, remitting, and it is in the same site, what are the what ways you become wiser? You see, we say that demyelination will become lower in the list. Because demyelinations can rarely only recur in the same site. That is called site-specific demyelination. Generally, demyelination do not recur in the same site. The reason being, normally, upper motor neuron contains oligodendroglial myelin, whereas lower motor neuron contains Schwann cell myelin. Supposing it's a brainstem cerebellar syndrome, due to upper motor neuron involvement, it is repaired by the Schwann cell myelin, which is present in the cranial nerves which belong to the lower motor neuron. So cranial nerves contain Schwann cell myelin that proximally proliferates and repairs the upper motor neuron myelinated brainstem structures. Generally, primary demyelinations presenting as brainstem cerebellar syndromes is a disease of the oligodendroglial myelin, not Schwann cell myelin. Whereas acquired demyelinations like ADAM, acute disseminated encephalomyelitis, which will involve both MN and LMN, that can involve both oligodendroglial and Schwann cell myelin. Whereas the primary demyelinating disorders involve oligodendroglial myelin and they do not recur in the same site because the repair is by the Schwann cell myelin, which is refractory to the process of primary demyelinating disorders. So brainstem cerebellar syndrome is the commonest form of childhood MS. Especially Western, we used to tell in the West, and in our country we say it is spino-optic MS. But now we know that in our country also brainstem cerebellar syndrome is the more common than the spino-optic. So the brainstem cerebellar type of demyelination which can relapse, recur, is becoming lower in the list. ADAM, that is acute disseminated encephalomyelitis, acute demyelination, they generally do not relapse. Very rarely they relapse. It's a monophasic illness. ADAM or acute disseminated encephalomyelitis infection, vaccination, associated demyelination is usually monophasic. It is not generally relapsing, even though there is exceptions. So Adam is monophasic. So either way, demyelination goes last in the list, and I will still want to stick on to an ischemic process, either due to a primary vascular anomaly or a bleeding disorder or a soft tissue anomaly in the cranial junction as the first possibility. And of course, the second possibility is demyelination, because it is site specific. If it is demyelination, if it turns out to be demyelination, you will have to use the term site specific demyelination. And because it is involving large segment in a symmetrical fraction, if it is demyelination, it will go to the category of tumefactive demyelination, tumor-like demyelination, which will be very huge, very large area, but they come very acutely, very difficult to differentiate from tumors. So it is called a tumefactive demyelination. It can be hemorrhagic, non-hemorrhagic. So these are the possibilities, because 2 episodes came acutely and improved. Anatomy, I am sure you understand, it is medulla, pons, ARAS, and the cerebellar connection. Second, 2 times recurred in the same site. So it can be vascular, either bleed or infarct. Second, it can be a large segment. So is it a tumefactive demyelination? Primary demyelination are less likely. And tumefactive demyelination, usually anti-MOG associated demyelination can involve the brainstem. And that is what I am thinking. Accoparent syndromes are involving the brainstem, but usually spinal cord will also be involved. They present with vomiting, severe, all those things are not there. So whether it is a accoparent related syndrome becomes a last possibility. These are the possibilities. NMO, that is NMO spectrum, accoparent. Those conditions can present with the repeated brainstem syndrome, and at one episode it can pick up the optic nerve and the spinal cord. That becomes the next possibility. So order is ischemia due to CVJ anomalies or due to AVMs. Second, is it a bleed? Recurrent bleed is very uncommon, so bleed becomes less likely. Demyelinations, it is site-specific demyelination, large. So is it a tumefactive demyelination, or is it an NMO spectrum disorder where it is starting with a brainstem, and then later we may get optic nerve and spinal cord features. So these become the differential diagnosis. Then you go to examination.
Yes.
You told you are given radiation. I do not want to give any significance to that, because many times demyelinations get radiated because it is diagnosed as tumors, and especially the MOG associated demyelinations can be very huge and it can be mistaken as tumors, and there are some radiological points. If you are not carefully looking into that, tumors never present like this. This presentation, if it is true, I will not diagnose tumors, and I know many times demyelinations get radiated as tumors.
Okay. Ma'am, should I skip this developmental?
Is there any new point in the other things you have told? You can say. If it is negative, no need. All vaccinations received, development is normal. Okay.
Yes. Yes.
Okay. Quadripesis with examine. Quadripesis horizontal gaze palsy with what is the polyuria? Polyuria.
Yes.
Okay. Why did you think? Yes, you told that point we did not discuss. Why don't you analyze that? Was she having increased thirst, ma'am?
No, ma'am. Ma'am, after admission, only she developed polyuria.
You see, polyuria can be due to several factors. One, polyuria associated with polydipsia. Polyuria associated with polyphagia. Polyuria associated with compulsive water drinking. Or polyuria related to diuretics.
Yes, ma'am.
Supposing you got polyuria with polyphagia, you think of conditions like diabetes mellitus. Supposing there is polyuria associated with polydipsia, you are going to think of conditions like diabetes insipidus. The lesion can extend from the pons, it can maybe midbrain was missed, or we do not know, because when you examine upward gaze also affected, means midbrain involved and go to the hypothalamus and produce diabetes insipidus. So if there is a diabetes insipidus, you get polydipsia or polyuria. And there is another condition called compulsive water drinking. Nature therapy and so many therapists, they drink a lot of water. So it's a compulsive water drinking, either as a naturopathy therapy or psychogenic.
Psychogenic.
Or you have a patient is given some diuretics, we don't know, for whatever reason you give diuretic, you can get polyuria. So when there is a polyuria, you should tell, was it associated with increased appetite, increased thirst, or for any voluntary increased drinking of water? Did the child receive any diuretics? If none of these things are there, we can imagine that there was diabetes insipidus. Then because everything is in the brainstem, it could have ascended up to the hypothalamic region, and the child would have developed a diabetic insipidus. Possibility is there, because it was so acute, and you have documented polyuria. Lot of IV fluid and diuretics was given, we don't know. If it was not so, in this context, it could explain that the lesion extended to the hypothalamus and resulting in diabetes insipidus. Yes, pons medulla, very good. Pathology. Why did you think of compressive? What is acute severe compression? No tumor comes acutely, and no tumor will resolve completely, even if you give 200 radiations and leave no residue and relapse after some time. So compressive lesion, you should delete it unless you are having a bias. No?
Okay.
So very unlikely it is a mass lesion. From this history and from this finding, from the pattern in which it has evolved, you will not diagnose a tumor. Because many times radiology can be misleading. There are some fine points which you have to differentiate a tumefactive demyelination. As I told, tumefactive demyelination, MOG associated, NMO spectrum demyelinations, they can all present in this region. They can be easily mistaken as tumor if you do not take proper history. But you have taken a proper history, then why you would put it as tumor? You have taken a proper
I was a little biased towards the history of radiation.
No bias, no. Because we are all prone to do errors, and you have to learn from our mistakes. I myself know that when during my student period, later in my career, I have seen demyelination being radiated in certain difficult areas, especially brainstem. You will not be able to take biopsy, and you are carried away by your images. Then you will radiate and do all these things. That is why we have to go into everything. There is no neurology without history. Without history, if you make neurology on shadows, we will make a lot of mistakes. And if your history is correct, you should cut off that compression.
Yes.
Anatomy, you definitely know. And pathology, acute, severe, relapsing, remitting, site-specific. That DDs only. So it's an acute, onset to peak is very short. It is the brainstem cerebellar plus minus extension to hypothalamus, complete remission, and relapsing in the same site. So here same site means site-specific demyelinating disorders. That is what MOG, aquaporin-related demyelination. They are preferring some sites only where these specific targets are there. So site-specific demyelinating disorders, that becomes the differential diagnosis. Mass you should not put. Mass, you will be surprised, because if you have a silent mass, which has an acute exacerbation due to a bleed into a mass, your mass may be there, which becomes acutely symptomatic due to a bleed happening into a mass. In that case, after you radiate, child will not be normal. You see, mass is there for a long time. It is not really silent because child is not complaining, parents are not observant, they may miss mild ataxia, mild imbalance, mild squint. Suddenly, when it bleeds, it might become severely symptomatic. But once you are given 20 radiations, it will not go off completely. It will definitely not go off. So because of these reasons, I feel I will not diagnose tumor at all if your history is correct.
Okay. I
Okay.
will cut this mass lesion.
Yes, ma'am. Then examine. Tell what did you find on examination?
Ma'am, in general examination, patient is lying on the bed in supine position, helplessly. Belt is normal, emaciated, conscious, vertical eye movements on command, pallor
Are
plus.
present. Vertical eye movements are present. Huh?
Yes, yes, ma'am.
In that case, midbrain involvement is less likely. It is medulla and pons.
Yes.
Okay.
Ma'am.
Vertical gaze center is in the dorsal midbrain.
Yes, ma'am. Ma'am, pallor was present. There was no icterus cyanosis, clubbing, lymphadenopathy, no hyperpigmentation, external markers of TB, and no neurocutaneous marker. Pulse was 68 per minute.
Vertical
Regular.
eye movements present, but why did you not describe the horizontal eye movements? Vertical eye movements were present on
Yes,
command. That means child was registering your command, internally conscious, appreciating and trying to obey.
Yes,
horizontal eye movements absent or present. What about optokinetic nystagmus, whether it is supranuclear, nuclear, infranuclear, we should know. Did the child have a squint or completely total loss of horizontal eye movement? When you did the optokinetic tape, could you do a movement? So, you know, it's a gaze center or intranuclear paralysis. That you should definitely you should describe that.
Ma'am, in general examination, I have mentioned only vertical eye movements. In cranial nerve examination.
Okay. Okay, ma'am.
Ma'am, pulse was 68 per minute, regular, normal volume, condition of the atrial wall normal, no radial and radiofemoral delay. All peripheral pulses well fed. BP was 1070 millimeter mercury, bilateral in supine position. Respiratory rate was 14 per minute. Regular abdominothoracic, no abnormal pattern, normal depth. JPP is not raised, no carotid bruit. Coming to central nervous system examination, in higher function, the child was conscious, vertically moves eyes on command, speech, comprehension was intact, but the child was mute. Memory could not be tested.
When do you use the term mutism?
Ma'am, if the patient is not able to tell any words, but comprehension is intact, then ma'am,
the child is wordless,
yes,
but the other language functions are normal. That is mutism. Can you tell me some conditions where you get mutism in a child? Or anybody, child or adult. One is psychogenic mutism. No?
Yes,
what is the term condition called where there is a psychogenic mutism? Catatonia. Heard of catatonia? Child will not talk, child will not move. Yes, the child may not eat also. In children, it is associated with NMDA encephalitis. You see, NMDA, N-methyl D-aspartate encephalitis can present with catatonia, where they are not communicating, not moving, but conscious. That is one condition you should never forget. In older people, it is catatonic schizophrenia.
Yes, ma'am.
Or other causes of catatonia. In the adults, it can happen. In children, catatonia and mutism is NMDA. Never forget that. N-methyl D-aspartate antibody-associated encephalopathies. Second level of mutism is psychogenic mutism, where it is not catatonia, but simply you don't want to speak. So you are not paralyzed, you are moving about, and you try to communicate with the writing. That is second type of psychogenic mutism. Third level of mutism is cingulate mutism. If you have a pathology in the cingulum, that is in the medial frontal region, then also you are mute there, because cingulum is associated with sham rage. Sham rage means you are aggressive against your own self and others. So cingulate mutism is associated with autonomic dysfunction in the form of episodes of palpitation, sweating, pupillary changes, and rage. That is cingulate mutism. Then you have got a frontal mutism. Frontal mutism is dysexecutive, severe dysexecutive bifrontal syndrome. And you have got a periaqueductal gray matter induced mutism, where you are quadriplegic and mute. So mutism can be psychogenic, where you are not talking but writing, or it can be a catatonia associated mutism, wherein a child, you should not forget NMDA encephalitis, or you can have a mutism due to cingulum involvement. The cingulate mutism, patient will have autonomic features like palpitation, sweating, pupillary dilatation, and rage. Frontal mutism opposite. Prefrontal mutism, they are severely dysexecutive, and you have got a periacital gray-induced mutism, where you are mute and quadriplegic. So this child may be periacital lesion, midbrain, brainstem is there, so it can be due to extension to the midbrain. Then another unusual syndrome, where mutism is the first feature in a language lesion, that is Mary's quadrilateral space.
Mary's quadrilateral.
Yes, subcortical language area, which involves external capsule, internal capsule, thalamus, caudate, globus pallidus, and putamen. That forms the Mary's quadrilateral space, which forms the schema producing area for language. So if that area is gone, you are mute because your language is there. You are not able to prepare the correct motor movement of the lips, the pharynx, and the tongue muscles to bring out the word. So patient will be mute. And once they start recovering fast, they will be severely dysarthric. They will have naming defect. They can have paraphasic errors. Then you know it is a language. So Mary's quadrilateral area, infarct or things like that, when the mute is coming, they are mute for a short period, followed that dysarthric, naming defect, paraphasic errors. That is Mary's quadrilateral space. These are the various locations where you get mutism. Your comprehension is intact, very good. That again means your word using mutism is correct. And memory could not be tested, right-handed. Okay, next one. E4.
Ma'am, in cranial nerve examination, olfactory nerve could not be tested. In second nerve, optic nerve also could not be tested. In third, fourth, sixth, upward and
Child
downward.
was having Manas reflex or what? Because there was no ptosis, no?
No ptosis.
And bring the fingers near the eyes like that, Manas, and see whether there is a blinking, or is the child showing familiarity when loud ones come nearby. Those ways you can see whether vision is there or not. Okay, next.
Ma'am, in third, fourth, sixth nerve, upward and downward eye movement was present. Horizontal movement absent. Pupillary reflex was present.
Okay, so that indicates a complete horizontal eye movement paralysis, probably gaze, because pupil is not involved, vertical eye movement are not involved, there is no squint. But in this context, it would have been nice if you have tried to elicit a optokinetic nystagmus. Because if you are able to, or caloric syringing, which we do not do, because you produce discomfort to the patient by injecting cold water into the ears and demonstrate eye movement is there. Simplest way to demonstrate is either an oculocephalic reflex or an optokinetic movement, where if some movement is there, that means it is upper motor neuron. Okay, next one. So that should have been done. Next time we will do that.
Okay.
Next one.
Ma'am, in fifth nerve, sensory and motor examinations were normal. Sensation over the face and middle pterygoid, lateral pterygoid.
Sensory motor absent means what? Child is not appreciating sensation.
Yes.
So there is total loss of sensation in the whole of the right side of the face.
Yes, ma'am. Ma'am, both sides, ma'am. Left and right.
Both sides. Okay.
Yes, ma'am.
And motor also, child is not able to chew or bite. Okay. No. Next.
In
bilateral seventh is present, huh?
Yes.
Don't put it as absent. Seventh is there now. Seventh cranial nerve and fifth cranial nerve is present for this child. So you will tell that child is unable to close the eyes. Yes, child is unable to blow the cheek, unable to close the lips. So I think that there is bilateral. You will not use the word absent. You will not say 5th and 7th is absent. You will say that total loss of sensation in the face, and muscles of mastication are not functioning, and muscles of facial expression are not functioning. Okay, next one.
I mean, 8 nerve air conduction was more than bone conduction.
That child was able to indicate.
Ma'am, indicate only through the eyes, ma'am.
Okay.
In 9th and 10th nerve examination, gag reflex was absent. Palatal movement was absent.
There was an LM1 component.
Yes, ma'am.
If it is UM1, gag should be present.
Yes,
gag absent means LM1. It can be due to the root exit zone of these cranial nerves getting involved. You can have an LM1. Okay, next. 9.
Yes, ma'am.
11.
11, the patient is not able to shrug its shoulder.
Okay.
Shrug their shoulder.
Okay.
And
not able to protrude the
not
tongue.
able to protrude tongue. No deviation of the tongue. No fasciculations.
Okay.
Ma'am, I want to show the video.
Yes,
eye movements.
Video is not moving, I think. I could not see the eye movements properly, I think.
Should I repeat the video?
Yes, ma'am.
Okay.
Eyes resting eye position, both eyeballs in the mid position.
Yes, ma'am.
And, okay. You must be correct only. I am not able to see clearly the horizontal. Your hand is coming in between, I think, in the record.
Yes.
Okay, ma'am.
Ma'am, in motor examination, tone was there was hypotonia in both upper limb and lower limb over all joints, bilaterally symmetrical. Power was 0/5 over all the joints, shoulder joints, in flexion, extension, abduction, adduction, elbow, flexion, extension, wrist, supination, pronation. Then, ma'am, in superficial reflex, corneal reflex was absent, jaw jerk was absent, abdominal reflex was absent, and plantar was extensor bilaterally. All features are, ma'am, present bilaterally symmetrical.
Okay.
In deep reflex, biceps, triceps was 3+, 3+. Then supinator 3+ bilaterally. Knee and ankle all were, ma'am, 3+ and 3+ bilaterally. Clonus, both patellar and ankle clonus were absent. There was no involuntary movements and gait could not be tested.
Okay. So are we any wiser than what we thought from the history? We are not. No. So I think the lesion may be going to the mid hypothalamic region also, considering your polyuria. It's a very long lesion, extending from the medulla to the hypothalamic region, acute. So I still hold on to my diagnosis of anti-MOG, NMDA, site-specific demyelination, and other differential diagnosis, which I considered as possibility. So let us see what happened after that. So after admission, what did you do, ma'am?
Ma'am, after admission, only symptomatic treatment were given. This
What
patient was
symptomatic?
admitted in ma'am pediatric ward.
Imagings you have? Do you have the MRI?
Yes, ma'am. MRI was.
Could you expand the brainstem?
Yes.
These pictures, can you magnify?
Ma'am,
Okay,
this is maximum. Yes.
Okay, ma'am, doesn't matter. Yeah, would you like to describe, ma'am? We'll start from the lowermost cut. Cervical cord does not seem to show much things. So when you are coming to the medulla, you are finding hyperintense signal changes involving the ventral medulla. And these seem to be multiple patches in the medulla where you have a large hyperdensity which is irregular lobulated towards the right side, and on the left side there's a small lobulated one, and you are seeing the basilar artery, and the basilar artery appears to be encased.
Yes,
encased means you can see the soft tissue over the basilar artery. With a mixed density brainstem, multiple hyperintense signals, which bulkiness and basilar artery is seen, and over the basilar artery you see a soft tissue shadow. That is, basilar artery is encased. And when you come little more up, the midbrain also shows a mixed density, patchy lesion, right more than left, and here also the basilar artery is encased. A very important finding.
Yes, ma'am.
You see the basilar artery there.
Yes.
And over the basilar artery, you see the brainstem tissue. Normally, basilar artery lies in the ventral groove of the brainstem. And over the basilar artery, there is no brainstem. Here you see the basilar artery, and over the basilar artery, soft tissue is there. That is called encasement of the basilar artery. So this, in this cut, you see that. In this cut, it is not very clear. So here again, it is mixed density. And the lesion goes to the midbrain also. Then do you have any higher sagittal cuts? Higher sagittal cuts are there? This kind of cuts. Whether hypothalamic region. So it's a long lesion extending from medulla to brain, more eccentric towards the right side, mixed density, no bleed. I'm not seeing any bleed, but with this, normally, no. If you had bleeds, hemorrhages, all those things, and in that situation, you will be able to sometimes suspect that it is a mass or demyelination. In this situation, I have difficulty, but considering the history, I will consider a MOG-associated demyelination as a possibility. Now, it's not an infarct from this. It's not an infarct. It is not in the vascular territory. It may be a tumefactive demyelination possibility still there, because it is a question of life and death for the child. It's a bulky brainstem extending from the medulla to the midbrain, mixed density, no hemorrhages, no vascular pathology. So is it a tumefactive demyelination? I would certainly like to rule out, and considering the acute severe onset with the complete recovery 8 months back and a relapse again happening, Whether radiation really helped, I don't know. I don't think also. So I will still like to rule out a tumefactive demyelination, especially in the brainstem region. Very difficult to do biopsy. You cannot do that, and unless there is a irregular, mixed density, dirty-looking lesion, subacute onset, slowly progressive, incomplete remission, presenting with intractable vomiting, coming from the medulloblastomas, other midline brainstem lesions, brainstem gliomas, you can think of. And brainstem gliomas generally do not have such extensive involvement. They are generally in the pons. Brainstem gliomas in children are in the pons. Medulloblastomas are cerebellum and medulla. And this long lesion extending from the medulla to the midbrain in an irregular, patchy fashion, not like the way the tumors expand. And complete remission, hyperacute onset. Why you will forget all this and just look at the brainstem? Somebody reported tumor and start treating it as tumors. I still feel it is a tumefactive demyelination. If it is not, it's okay. But before giving a giving a fatal diagnosis to a child who has a hyperacute presentation, complete remission, where radiation might not have had any role, child might have recovered on the own. Or when you give radiation, you naturally give steroids. The steroids would have worked and not the radiation. You see, when you radiate the brainstem tumors, they become more sick because all the structures are there and radiation produces edema. They become more sick. Here the child, initially at least, here the steroids should have helped, not the radiation. So I still feel strongly that you should rule out a tumefactive demyelination, both clinically and radiologically, not very typical of tumor. Tumors do not go like this long way if it is an exception rather than an example. So this type of presentation is unusual for the following reasons. One is hyperacute onset, bilateral severe symmetrical, and very short period of complete recovery, long remission of about several months, and again recurring in a hyperacute fashion, and the lesions patchy in the brainstem, long longitudinal extension.
Yes,
I will still consider tumefactive demyelination. You can do the antibody screening with anti-MOG, NMO, even if those are negative.
Yes,
give steroids, methylprednisolone pulses, and wait. By radiating, we are not going to give anything to the child. Brainstem tumors carry very poor prognosis. So that can wait. You need not do that. Instead, you can give methylprednisolone. That can be a therapeutic trial. And you see follow-up images, whether these lesions are disappearing. I still feel it is a demyelination. Tumefactive demyelination will be my diagnosis, my first diagnosis. Brain biopsy is difficult. These areas are always like that.
Yes, ma'am.
Any question, ma'am? Because we have strong clinical features now. Hyperacute, complete remission, symmetrical, no? Very long longitudinal extent, non-contiguous, patchy lesion. No?
Yes, ma'am.
I will think of a site-specific tumefactive demyelination, which does happen with MOG.
Yes, ma'am. Now only steroid is given, but in the last episode, what are the treatments? I don't know.
Now you give methylprednisolone. You can give methylprednisolone, 500 milligram for 5 days, and then follow it up with the tapering dose and repeat the images after 4 weeks. If you have no facility to do the antibody, it is okay. You can repeat the images after 4 weeks.
Okay.
I think it is tumefactive demyelination. First possibility, we can always wait to diagnose a tumor when so many features are so atypical.
Ma'am, in the last episode, when MRI was done, and comparing to this episode, they were written that size of the lesion was same, which was present before also.
But
And
complete remission was there, no more.
Yes,
in 7 months. It will not happen. Size of the lesion, they are all very soft signs. You see, brainstem tumors and brainstem tumefactive demyelinations are close differential diagnosis. Only thing which can sometimes remit completely is lymphomas.
Okay.
Very unusual, location for a lymphoma. Very rarely it can happen. Non-Hodgkin's lymphomas can sometimes present as intraaxial lesions, in which situation it can remit completely and then relapse. That is the tumor which can remit completely with steroids, but very less common.
Yes, ma'am.
So that is my diagnosis again. It's a good case.
Yes, ma'am.
You can do a brainstem localization. I think one class I took on brainstem localization along with eye movement. I think so. Is it for yourself or some other class? I don't know. You can ask Vijay whether I took brainstem for you or not. For the white army or not. I have taken eye movement, I know. Brainstem also I have taken. I don't know whether it is for the white army or for some other sessions. I don't know. But complete brainstem localization I have taken. If it's not for you, I can take one. You can tell Vijay to find out whether I have taken brainstem localization theory class. If I have not taken one occasion, I shall do that.
Okay. Okay.
Any question, ma?
Ma'am, should I call this as a locked-in syndrome?
You see, locked-in syndrome, a term is non-specific. It does not give you a diagnosis. Locked-in syndrome can be end stage of severe Parkinsonism, tetanus, tetany, or ventral pontine syndrome, akinetic rigid syndrome, or it can be periacidital gray syndrome. So locked-in syndrome means you are conscious, you are able to comprehend, you are unable to communicate. So that does not give you a diagnosis. It does nothing to do with your disease.
Yes, ma'am.
See, you can use the end-stage Parkinson patients. They are locked in. Severe Guillain-Barré syndromes, they are locked in. No, the only relevance is they are conscious, and because they are motionless. Sometimes they are considered dead people, no? And people take organ donations. This has happened. So locked in means you are conscious and you are unable to communicate. That is locked in. That's all. So locked in can be LMN, it can be EMN, it can be any brainstem syndrome, depending on the accompaniment, ventral pontine syndrome, periacidital gray syndrome, akinetic rigid syndrome, persistent vegetative states. No. All these come under locked in, including end-stage Parkinsonism, catatonic schizophrenia. No. All these are locked in. You can call it locked in, but it does not make you any wiser.
Okay.
It does not give you any useful diagnosis. It only gives you a terminology. The locked in terminology is useful to say that patient is conscious, do not take his organs for donation because he is lying down and not communicating. Don't declare him brain dead without doing the proper brain dead test.
Yes,
he may be alive inside. That is the only purpose that is served by using the term locked in. Otherwise, it is neither diagnosis nor pathology. Localization depends on the accompaniments. End-stage PD patients are locked in. They are rigid, stiff, no?
Yes, ma'am.
So they are also fully conscious. Ventral pontine syndromes, periacidital syndrome, persistent vegetative syndromes are not actually conscious. So this, depending on the location, you call them locked in means they are conscious, they are locked inside their own self, unable to communicate. That's all. It is a clinical syndrome. It does not give you diagnosis. It does not give you treatment choice. It's a terminology. You can use it, but not at the end. When the child comes to your OP, you can call her locked in. After that, you will call her as a long brainstem syndrome, which extends from medulla to hypothalamus.
Yes, ma'am.
Any other question, ma?
Ma'am, in GCS scoring system, before it was told that if the patient is on brain
score is of not much use in this child. Glasgow Coma score is to assess the sinking of the depth of consciousness in conditions like head injury. Here the child is paralyzed. Eye movement system is paralyzed. So Glasgow Coma scale is used to assess the degree of consciousness. When the end organs are paralyzed, this score has no relevance.
Okay.
the child is not moving, not talking, not because of consciousness,
Yes,
but because the executive apparatus has failed. So GC score is not important. Head injury patients, such situations where the brain is injured and the consciousness is affected, deteriorating consciousness can be assessed by GC score. But when there is so much of paralysis,
yes, ma'am.
it is not anymore a tool of consciousness assessment.
Okay.
Anything else, ma'am? Any other question? Very good patient, very nice presentation. A lot of things to have been, yeah, if I had gone into the brainstorm, we will not come out till midnight. So I did
Yes,
not
ma'am.
enter that. We just see whether I have taken a class on brainstorm localization, any
Yes,
of the previous sessions, because I take some other sessions also. I don't know where I did what. So if it is not there, I can do once. You would now go and study the sections through the midbrain, sections through the pons, sections through the medulla, medial medulla, lateral medulla, paramedian Pontin syndrome, lateral Pontin syndromes, and brainstorm. There are 5 syndromes. Thalamomesencephalic junction. Then you have got a dorsal midbrain, then median, paramedian, lateral. So midbrain there are 5 zones. Pons there are 2 zones. Medulla there are 2 zones. So and then purely intrinsic, purely extrinsic, and intrinsic plus extrinsic in the brainstorm. So that is the localization. So today, go and draw the diagrams through the midbrain, pons and medulla, and fix it in your brain.
yes.
Okay.
Thank
Any
you.
other question, ma? No. If there are no questions, we will close. Thank you. Nice, you well presented well, ma.
Thank you.
So it is good to say logged in at the beginning. At the end, you will talk about the etiology and pathology.
Yes,
I
yes.
still would like to consider demyelination for this sweet child. Okay.
Yes, ma'am.
Should we close, ma?
Yes, ma'am.
If there are questions, I will answer. Otherwise, we'll close. We'll close, huh?
Yes, ma'am. So it was indeed a very comprehensive class, ma'am. Actually, the discussion was very useful to us. And thank you so much for teaching and guiding us, ma'am. We are ever grateful to you.
No,
And,
need to be grateful, ma. Yes, you say it is my opportunity to thank my teachers. Only thing I feel sometimes that everywhere, of course, yeah, young children think that doctor and patient are 2 different things. We are not. You see, I have given one talk on art and science of medicine.
Yes, yes.
Just because people are beating us, we will not harass them because it is only different phases. All doctors become patients. And some of
Yes,
our children whom we treat, who are our patients, will grow up to be doctors and they will treat us. So this is a different role play. At one point, a doctor is a patient, and another point, a patient is a doctor. So these are not 2 different castes, or 2 different groups, or 2 different races. So that's the way our children everywhere seem to think. The junior doctors are very aggressive. Of course, they are beaten, but everybody else is also beaten. There is road rage, there is office rage, there is rage to steal, kill, rob. Everywhere, top to bottom, there is Kali Yuga, is Rutra Dandavam is going on. So it's not specifically directed against us. It is a way in which the human race is deteriorating. We who have chosen the noblest profession in the world will stand out and tell, let anything happen, I will maintain the purity of my profession. I will love all the strangers who pass through my hands, and I will treat them with utmost sincerity and commitment. And never train your mind to think patient as another category who is going to beat you, kill you. Now I am in a small private hospital after I retired. There the young doctors are going on posting as if patient is your enemy. If there is no patient, where is the doctor?
yes.
Imagine a doctor with super specialty degree and crow catching or housefly catching thing you do. What is the use of your degrees, ma'am? So patients are the most important visitors to us. If there is no patient, there is no doctor. And there is nothing called doctor or patient. Both posts are exchangeable at any time in our life. So continue to love the patient, continue to improve your subject, continue to be committed, sincere to the best of your capacity, and prove that you are superior citizens of this country who have chosen this profession by choice. You will never hate a patient, because tomorrow we may be patient and our patient might treat us as a doctor. No. So never categories like that. That attitude is there, because I am now retired in the private sector. I am afraid of my junior colleagues. They might come and hit me when I tell them things like this. But because you are students and budding futures of this country, if you do not keep up the nobility of this profession, nobody else can. By proving your superior merit, I'm sure you can win over the rebellious persons also. There are rebellious persons, there is no doubt about that. Let them rebel. We will not. We will prove the purity of our profession to the world. That is what you should think. So you don't have to thank me. I'm thanking my teachers, my parents, my country, and all of you for giving me this opportunity. Thank you so much.
Thank you.
Yes, ma'am. Your words are really enlightening, and we'll take this a long way throughout the journey, ma'am. Yeah, thank you. And I also thank the presenter who did a very good job, and we could learn a lot because of your well prepared presentation, doctor. Thanks to you also.
Thank you. Thank you
And
so much.
yeah, and thank you for all of you who have joined us via Zoom and YouTube. And yeah, let us meet in the next session.